We will continue on with the next speaker, who is myself.
Professor Stephen Wong is currently president of the Asian Musculoskeletal Radiology Society, and he's a big educator, and he participates in a lot of events international, and we was a lecture about the MSK. We are honored to have an opportunity to receive him here today. Thank you.
Thank you very much for a kind introduction. Thank you for the kind invitation to share. This topic is due to the fact that my residents cannot report scoliotic X-ray spines, right? So I thought I'll do a lecture for them. So this is actually at residency level, but so maybe a bit simple for majority of you. Scoliosis is very often an incidental finding. This is one of the health screening chest X-ray that we get very routinely. Patient was initially worked up for knee OA. In another case, in this one, the patient was worked up for a knee OA, and then you did the whole spine. You can see that because of the OA, the angulation, the knee joint, the spine is unstable, and the spine has changed its angulation and alignment to cope with the patient's knee instability, right? So lateral spinal curvature with a COP angle of 10 degrees or more in the coronal plane is the official definition for scoliosis. But unfortunately, coronal plane is only one single plane. Scoliosis affects the spine in all three dimensions. So you actually do need to try and image the patient in as many planes as possible. First is the initial stage, which is the curve initiation, and then later on progression of scoliosis. So the Hütter-Volkmann law states that a bone growth in the skeletal in immature spine is due to retardation by bone growth compression or accelerated by bone growth tension or distraction. Compression force acts at the anterior aspect of the spine, and distractive force acts at the posterior aspects of the spine. This often leads to secondary rotation of the vertebral bodies in the axial plane, and also within the coronal plane as well, when you have one side is higher than the other. This causes discrepant axial loading pressures in the spine, and that leads to progression of the scoliosis. Etiology, idiopathic is the most common, congenital. There's also developmental, patients with dysplasia, achondroplasia, neurofibromatosis, patients with neuropathic pain or myopathic pain, muscular dystrophy, muscle wasting from neuropathic problems, and also those with tumor or infection. As a result of tumor infection, you end up with scoliosis because of destruction of the vertebral body. By and large, idiopathic causes is 80%, congenital causes 10%, and you do need to look out for patients with segmentation errors within the spine. So what do you look out for? Like I say, segmentation error, not very often, but it does appear. So if you get a chest X-ray and you look at it, it doesn't look quite right. Look and see whether the vertebral bodies are normal or not. CT is the next gold standard modality to evaluate, with, especially if I can do a 3D VRT version to help better visualize the type of segmentation anomaly. Patients with tethered cord is another category where, because of the shortening of the thecal sac or the shortened length of the cord, and the cord has problems lengthening, the spine cannot elongate or grow as normal. So how do we report? First, you locate the central sacral vertical line, CSVL. I just call it a central line. All right, so this is a line perpendicular to the upper margin of the iliac crest. And you can stop taking photos now, okay. Right, and it bisects the sacrum, right, this way, okay. And you then determine, it must be 90 degrees, and then you determine where the curve is. If we follow the surgical convention, the surgeons always talk about convex to the right or convex to the left. Surgeons never talk about concave to the right or the left. So you've got to use the terminology that your surgeons are comfortable with and are used to. You don't want them to do it on the wrong side. Then you determine which is the apex. The apex of the scoliosis is the one that's furthest away from the central vertical line. Then you determine the end vertebrae of the scoliosis. This is the one that has the maximal tilt towards the apex. Same number of vertebral bodies above and same number of vertebral bodies below the apex. And this is where you measure your cup angle. Then the neutral vertebrae, something that usually we don't mention in the report, that there's no need to mention in the report, are those where at the either ends of the spine, there's no rotation, there's no tilt. And the stable vertebrae are those furthest away that are bisected by the line. So what is the cup angle? Everybody knows how to measure it. You find your end vertebrae, and then you draw parallel lines and translate across and determine this angle. And nowadays, with wrist packs, with any capable packs can measure the cup angle for you without you having to draw the lines. But knowledge of how to draw the lines is very important because the surgeon draws the line themselves in their clinics. And unlike us, surgeons reverse the film. So you actually need to learn to look at the film in the reverse direction. And the main reason why the surgeon reversed the film, then turn it the other way around, is because that's how they see the patient on the operating table. Right, so their measurement may not be the same as your measurement, so you need to learn and have an understanding with your spine surgeon how he quantifies his cup angle. Right, okay, so we do turning. So when I report a spine, I'll actually rotate it, just have a look before I do how we normally report. This concept of the C7 plumb line, if you do carpentry or home carpentry, whatever, the plumb line shows you the true vertical according to gravity. It's a vertical line from the center of C7 vertebral body downwards. And it shows you the tilt and lateral tilt of the spine relative to the central line. It's more important when the surgeon wants to do the correction for the patient's tilt, particularly the patient in this case, have a mild pelvic tilt, right? The central vertical line may be tilted at a degree from the normal, right? The C7 plumb line is also important when assessing the stability of the spine in the lateral position. And I do advise that when patients come for a whole spine standing x-ray, you try and get your team, your technologists to do a lateral view as well. Because you want to see the alignment of whether it's neutral, whether the plumb line is in front or behind the vertebral bodies. Right, so by illustration, this is what you look out for. Relative to the distance to C1. So there's a lot of talk on how to determine the primary versus the secondary curve. And you used side lateral flexion x-rays on the right to the left to determine the curve. I used to report this in my reports and work it out until my surgeon tell me don't bother. They'll determine it themselves after they look at it. And invariably, we're wrong, and they're correct. So I stopped doing this. But this is how you do it. So the primary curve is the largest abnormal curve that you have. So you determine that, right? And it's the first one to appear. The rest, the minor or secondary curves, are the later curves, right? And they are basically to compensate for the loss of alignment of loss of sagittal alignment of your spine, and is literally meant to move your cervical spine and the base of the skull back to midline as much as possible. So scoliosis will progress over time, so patients unfortunately will need sequential follow-up x-rays. coronal plane, lateral if needed, if you think there's degree of instability. Usually by the time late teens, early 20s, the scoliosis should stabilize, shouldn't get worse. This is for mostly for the idiopathic type of scoliosis or the congenital, not the developmental ones, okay? So when do you continue follow-up, all right? It's supposed to only progress during the growth phase and cease when you have skeletal maturity. So how do you determine when is skeletal maturity, right? There's a lot of criteria. You look at the Cobb angle and see whether there's progression of Cobb angle year on year, all right? Cobb angle is affected by a lot of stuff. Height increase for the patient as normal. You know, kids grow up, and if not corrected, their scoliosis may get worse. In girls, they are pre-menarche status, or when they achieve puberty, is usually earlier than boys. And sometimes, once they reach that phase, their scoliosis may actually accelerate, and get worse for a period of time. So you actually do need to have a close follow-up for them. The Riser scale assesses the skeletal maturity based on your iliac crest apophysis. This is, you know, you can just Google it for anywhere. And it's basically ossification starting from the anterior aspect of the iliac crest all the way down to the posterior portion. Right, and another element is, do you really need to assess the degree of rotation on the, of the vertebral bodies on X-ray? You can if you want to punish yourself. I've actually stopped doing it because I know invariably my patients will come for a CT scan or come for MR, and I'll do the measurements of the rotation then rather than doing it. But you know, in the old days before there is MRI and CT, you can look at the position of the pedicle relative to the centrospinous process and the lateral aspect of the vertebral body and determine the degree of rotation. But nowadays, just go and measure it on the CT or MR. Again, there are multiple variations. I like the arrow Dalbond method because it's the simplest. And it's just basically an angle between the midline and the central vertical line here, right? And you just measure the angle there, right? The Ho et al. Is a little bit more difficult and a little more tedious, but is more accurate because it takes into account the orientation of the lamina at the back. So what would Stephen do, all right? So you have a female patient with adolescent idiopathic scoliosis. So we just follow to maturity and see. And in this case, at 13 years old, you can see she was put into a brace for a while to stop the primary curve getting worse. And if you follow it, she actually got better over time. She was an active sportsman. She does running and stuff. And by the time she's 19, it's fairly stable. You don't really need to do anything, all right, at 19 years old. So you can do all the measurements you want if you need to, and then you can determine. But if you go back and show the degree of progression to your surgeons and tell them there's no progression of the primary curve, usually the surgeons will be quite happy with that, all right? And you can do the lateral bending and see whether there's any worsening of the angle as well, okay? If the patient has persistent pain, unfortunately, or presence of pain developing, it may well be that the curvature is causing some degree of nerve root impingement. So you unfortunately will need to do an MR or CT and then assess the degree of rotation and also the alteration in the angle of the vertebral body in the coronal plane as well, because that will affect how big the neuroaxial foramen is on the concave side versus the convex side, and whether there's any disc problems at that level. So this patient eventually had spinal stabilization, right? So this, I spoke briefly about this morning about the position of the spinal cord or the cauda equina within the central spinal canal. This is relevant for surgery. Keep in mind on this. You can see this. Oops, sorry. Right. In this patient with pretty severe scoliosis, you can see that the cauda equina changed position within the spinal canal. So you do need to tell the surgeon, because you don't want him to putting a drill through the thecal sac and into the cauda equina or the spinal cord when he does stabilization, particularly in the thoracic spine. Okay. Weight-bearing low-dose cone beam CT have a role, and more accurate, unfortunately, not as commonly found as possible. A lot of the vendors now have fluoroscopic units that can do head-to-toe scanning in the erect phase, so negate having to do this. But it's very helpful, but the patients have to stay still for about 10 to 15 seconds for acquisition. And if you have an unsteady spine, you can imagine how difficult it is to remain stationary. Right, for patients with degenerative scoliosis, underlying spondylolysis, spondyloarthropathy, spondylosis, degenerative disc disease, this is usually progressive. And they usually present with pain due to cord or nerve root compression. And it's generally not reversible. Just do the usual measurements with the central line, determine what degree of deviation from the normal, and just report it to the surgeons, and they will just follow up accordingly. You can do all this analysis on your studies. So basically, for the degenerative scoliosis, find the apex, see whether whether there is subluxation in the coronal and sagittal planes, AP lateral or anterior, posterior, or lateral. Look for rotation of the vertebrae and asymmetrical disc spaces. And in this one, there is everything, all right? You have lateral listheses, asymmetrical disc space narrowing. All this will mean that it will never straighten itself. It will just get worse. Eventually, the patient will end up with pelvic tilt because of the tilt of the body towards the one side or the other, and just get x-rays, okay? Right. So for this patient, I would advise when they come for MR, do a coronal MR sequence. Right. Let's move on. Okay. Let me carry on. Let's see. All right. All right. So that's my answer to using a cine loop. I just fade them in. All right. Okay. Okay. Interest of time. Let's skip this. And for this, you can just to illustrate the change in the position of the neural exit canals relative to the cauda equina within the central spinal canal and the tilt of the patient. Okay, so sometimes you may have to tell your techs to do a oblique axial just to show the proper dimensions within the spinal canal. Right, so rotation, you find the maximal rotation of the vertebral bodies and determine it. I used to actually give angles to the surgeons. There are some who like it, some who don't. Right, degenerative scoliosis are very hard for the technologists to position in the scan because they are very stiff. They usually have back pain and they cannot lie still for too long. So you have to tailor your sequence. Management, really not for me to talk about because I'm not a spine surgeon, and it's a lecture in stuff. There's a lot to talk about depending on the preferred surgical method within your hospital. So in conclusion, in the first initial setting, scoliotic spine x-rays can look really difficult to report, but just keep the basic principles in mind. Where is the primary curve? Where is the secondary curve? Determine the central line and what the deviation from one side to the other. Look for the apex and look for the end vertebrae and measure the Cobb angle. If you want to rotate it, flip it to have a look at what the surgeon looks at, but remember to flip it back. Certain packs, once you flip it, it stays in that position. And always consider doing a CT or MR for this. All right, so here we go. Okay, oh, I forgot animations for that. So these are the references that you should look at if you want to take pictures of that. Okay, so there are 3 excellent articles. And with that, I thank you very much.
Okay, thank you very much for clear and excellent presentation. We let's discussion later. Sau đây thì là xin